Greetings and welcome to the BRCA Mutations in Men, Prostate, and Other Cancers presentation. At this time, all participants are in a listen-only mode. You may submit your questions via the web at any time by typing them in the Ask a Question field on the left side of your screen. Questions will be addressed at the end of the program. As a reminder, this conference is being recorded. If anyone should require technical assistance, please click the question mark icon on the upper right-hand corner of your screen. It is now my pleasure to introduce Pamela Klein, Vassar Center Outreach Manager. Please go ahead.
Thank you, Diego. Good afternoon, and thank you for joining us for today's webinar. The Vassar Center for BRCA at Penn Medicine's Abramson Cancer Center is solely devoted to BRCA-related cancers. The Vassar Center supports cancer care and BRCA research at every stage, including communication, outreach and risk assessment, prevention, early detection, treatment, clinical trials, and survivorship. Dr. Edward and Merry Prostic have generously established this webinar as part of the Elizabeth Prostic Memorial Outreach Program in memory of their daughter. The following video is a tribute to Elizabeth, her incredible life, and her dream of creating communities that increase awareness about BRCA and metastatic cancers. The Vassar Center is proud to be a part of this mission by providing life-saving information and hope to individuals and families worldwide. Please begin the video.
Tomorrow, bet your bottom dollar that tomorrow
Merry Prostic was an amazing young woman who believed in the promise of tomorrow. And though her tomorrows were cut short, we can celebrate and sustain her optimism. Lizzie lived large. She loved the stage and brought it to life with her voice and her energy as a talented child and as she grew into a woman. Her world was full of loving friends and family, and success in class, in sports, with girls, and with boys. Sophomore year of college, Lizzie met Michael Lundblad, a liberal and an English major. He got a preview of her leanings when he saw her quizzing a friend about senators. But she learned to love camping. He learned about couture. And political opposites, Michael and Lizzie spent 10 years together, marrying their minds and their passions. Michael loved her boldness and her softness, her interest in so many different types of people, and ability to remember the small details of their lives. The time she made to talk with her grandmother, her pearls, her red shoes that said she was not afraid to be noticed. She was not afraid. Lizzie's intellect and drive were rewarded with exciting opportunities. She blazed through the University of Pennsylvania and into the halls of government, determined to win in every venue and for every cause that was important to her. Her work for senators and on committees quickly made her a Washington insider. She rose to Chief Privacy Officer and Senior Advisor to the Secretary of Commerce before being lured away to the private sector. Not yet a lawyer, she was named Managing Director at Sonnenschein, Nath, and Rosenthal in Washington, D.C., and was completing her law degree at night at George Washington University when she died. When Lizzie was awarded a posthumous degree at the law school graduation, the entire audience stood in tribute to her spirit. Lizzie was 31 when she was diagnosed with stage 4 metastatic breast cancer, and her daughter Harper was 4 months old. Michael did research. Lizzie didn't want to know the odds, expecting to beat them. But the cruel reality was that although breast cancer is generally curable, metastatic breast cancer is not. And they found little support to help them deal with the psychological and emotional realities they had to face. In her last months, Lizzie and her family began to envision an online support network that would show patients with metastatic disease that regardless of how long they have to live, they have the ability to control how they live. This was Lizzie's final cause, and one which will be honored. Lizzie wanted to see her daughter's first birthday. She didn't make it, but she lives on in the people who loved her, and through grants such as this one being made in her name. And in truth, none of us knows how long we'll live, so we all should listen to Lizzie and make the most of every tomorrow. Live large, live strong, and wear red shoes.
Today's program will discuss the prevention and treatment of cancer in men with BRCA mutation. You may type questions into the Q&A box on your screen. We will try to answer as many questions as possible during and at the end of the presentation. Today's program will be archived and available for on-demand viewing. I'd like to introduce our speakers, Dr. Susan Domchek and Dr. Justin Bekelman. Dr. Domchek is a board-certified medical oncologist, Vassar Professor in Oncology at the Perelman School of Medicine at the University of Pennsylvania, Executive Director of the Vassar Center for BRCA, Director of the Mary and Robert MacDonald Cancer Risk Evaluation Center at the Abramson Cancer Center, and a Senior Fellow at the Leonard Davis Institute of Health Economics. Dr. Domchek has committed herself to pursuing research related to genetic susceptibility to breast and ovarian cancer, particularly with regard to risk assessment, screening, prevention, and treatment. She is especially interested in the development of targeted therapeutics in this population. Dr. Bekelman is an associate professor in the Department of Radiation Oncology and the Department of Medical Ethics and Health Policy at the Perelman School of Medicine, associate scholar in the Center for Clinical Epidemiology and Biostatistics, faculty in the Center for Health Incentives and Behavioral Economics, and senior fellow at the Leonard Davis Institute for Health Economics. Dr. Bekelman leads research programs in cancer comparative effectiveness and delivery system and payment reform, integrating methods from the fields of epidemiology, clinical trials, health economics, and public policy. Currently, Dr. Bekelman leads a 22-institution randomized clinical trial comparing proton to photon radiation therapy for breast cancer, and co-leads a randomized clinical trial comparing proton to intensity-modulated radiation therapy for prostate cancer, the first randomized trial of proton and photon delivery in the modern treatment era. Dr. Domchek, the floor is yours.
Thank you very much, Pam, and thanks everyone for joining us today. I'm going to start the presentation by reviewing issues related to BRCA mutations in men. We hope that this is interactive, so feel free to put in your questions as we talk. We'll try to address them and as we go, and we'll leave time for questions at the end as well. So just as an overview, BRCA1 and BRCA2 are genes that everyone has and are born with, and these genes help repair DNA damage in the cell. So they are very important for the repair of damaged DNA and also keeping your cells healthy. When someone has a BRCA1 or BRCA2 mutation, however, they are at increased risk for the development of cancer. And basically, the way to think about it is if you're born with one bad copy, those cells do fine, but if a second copy is lost, the second copy is lost, then a cancer develops. Importantly, both men and women can carry mutations in BRCA1 and 2. Again, these are mutations in the DNA that people are born with, and they can be passed along to the next generation. If an individual, either a man or a woman, has a BRCA1 or 2 mutation, there's a 50% chance that each child that they have may have this mutation. And oftentimes BRCA1 and BRCA2 are equated to women's cancers and a problem for women. But as we will emphasize, there are risks to men, and there are also risks to their relatives. So it's a very important thing to keep in mind. So when we talk about hereditary cancer in general, when we worry about whether or not there may be a gene mutation in a family, we look for specific hallmarks. And some of these include cancers in multiple generations, so grandparents and parents and children all having some cancer, particularly the same type of cancer. We look for cancer at younger ages. Individuals who have had multiple cancers, so for instance, for women, maybe a breast cancer and then an ovarian cancer. For men, it might be prostate cancer and a male breast cancer. We look for clustering of rare cancers, and those include male breast cancer, because male breast cancer is actually relatively uncommon. And that gets into also the issue of cancer that's in the less usually affected gender. So by this, we do mean male breast cancer as an example. And there are certain hereditary cancer syndromes that can be more common in certain ethnic groups. And for BRCA1 and BRCA2, the best example of this is that individuals who are of Ashkenazi Jewish ancestry have a higher risk of having a mutation, and I'll get into that in a little more detail in a minute. Now, it is true that sometimes we don't really, if you will, notice that a family seems to have a BRCA1 or 2 mutation. And there's a few different reasons that this can be, if you will, hidden. One is that there's never a 100% chance of developing a cancer, even if you have a BRCA1 or BRCA2 mutation. You still can be lucky and never develop a cancer at all. Secondly, although there are risks to men, those risks tend to be somewhat lower than for women. And the risks for women also occur earlier. So women can get breast cancer, for instance, in their 30s and 40s. And so when there's families that don't have many women, sometimes these genetic mutations can be hidden. And in addition, some individuals don't really view their father's side of the family as important. So sometimes it's not necessarily hidden, it's just not recognized by physicians or patients. Sometimes the family is really small. If you're an only child and your dad was an only child and the grandfather was an only child, it's very easy for this to be hidden. The family history can be unknown or uncertain. Unfortunately, particularly in the Jewish population, there can be whole generations that have died in the Holocaust. Sometimes people are adopted, so they don't know their family history. When individuals die young of other causes, if you will, they don't have a chance to develop a cancer. And finally, women who've had their ovaries removed for other reasons can reduce both their breast and ovarian cancer risk. So another reason that this can be hidden. So it does take paying attention to figure this out, and it's extremely important that individuals know their family history and discuss that with their providers. So in general, if you take the general population, about 1 in 400 individuals will have an inherited mutation in BRCA1 or BRCA2. But if you look at individuals who are of Ashkenazi Jewish ancestry, that number changes dramatically to 1 in 40. And if you're Jewish and you're in a synagogue on a Saturday, if you think about that, that is a pretty striking figure. So this is about a 10 times higher chances in the general population. In addition to being more frequent, it turns out that there are 3 specific mutations that make up about 90% of the mutations. And these are called founder mutations. The way that I often explain this is if doing genetic testing is like reading a book like War and Peace, where you're looking for a spelling error in this extremely long book. If you are of Jewish ancestry, you only need to look at 3 words in that entire book. And most of the time, if there's a mutation present, you will find it. So it makes the testing cheaper and faster and much, much more straightforward. And so this is an important aspect, whether people are of Jewish ancestry. And we really do try to do a lot of counseling in physician education about asking this very important question. But again, BRCA1 and 2 mutations are seen in all populations, in all races. They just tend to be much more common in the Jewish population. We are often asked who should consider genetic testing, and this is a very short, streamlined list. It doesn't include all situations, but all women with ovarian cancer, all men with breast cancer, any Ashkenazi Jewish individual who has breast, ovarian, pancreatic, or high-grade prostate cancer, early onset breast cancer, triple-negative breast cancer under age 60, this is a specific subtype of breast cancer, and the personal history of prostate cancer with a Gleason of greater than or equal to 7. As Dr. Bekelman may expound upon, this is just a way that we keep track of the type of prostate cancer people have. It's, we used to think of prostate cancer sort of all one type of cancer, but really there are different subtypes, if you will, and these are the higher grade, more aggressive prostate cancers. So individuals who have a high-grade prostate cancer and a family history are now considered candidates for genetic testing, and this is relatively new, this real recognition that high-grade prostate cancers should at least merit a closer look at the family history to see whether or not genetic testing is warranted. Now, when do you get genetic testing? This differs for men and women because what the general philosophy of genetic testing is that genetic testing is performed at around the time that it would change medical decision-making. So as you can imagine, some people want to know earlier than that, but generally speaking, men are tested at around ages 35 to 40. And for women, we do testing at around 25. And that's because for women, if individuals have a BRCA1 or 2 mutation, we start breast cancer screening at 25. Now, there are other things to consider. So those are the ages at which to consider testing just based purely on medical management. But people have other reasons to get genetic testing. And one of these is just out of interest, just knowing one way or the other. But another thing is that you can use reproductive technologies. So if you're planning to have children and you have a BRCA1 or 2 mutation, some individuals do use something called preimplantation genetic diagnosis. And what this is that individuals can go through in vitro fertilization, have the embryos screened for the BRCA1 or BRCA2 mutation, and have the embryos reimplanted in the uterus, the embryos that do not have the gene mutation. And this is the technology that's available. People have very strong feelings about this one way or the other, but we'd like to let people know that that technology is available. We generally do not test children because there are no known interventions in children to decrease risk, and there's no clear increased risk of cancer in children. So for that reason, we feel that individuals should make their own decisions as adults about when they wish to undergo testing. Here is listed in this table are the lifetime BRCA risks for men. As you can see, the risks are higher for men for BRCA2 mutations, and there is specifically an increased risk of male breast cancer with a lifetime risk of about 5 to 10%. And this is in contrast to an average man in the United States without a mutation of 0.1%. So you can see that this, although is not a terribly high risk, it is still very much higher than in the general population. The risk for prostate cancer is higher and appears to occur earlier for BRCA2. For BRCA1, it's a little less certain. And as we'll discuss in more detail, BRCA2-associated prostate cancer tends to be of higher grade and so certainly taken seriously. For pancreatic cancer, the lifetime risk in the general population is in the 1 to 2% range. And as you can see, BRCA1 and BRCA2 mutation carriers appear to have a somewhat elevated risk. This is particularly true for BRCA2. And there may be an increased risk of melanoma for BRCA2. There can be sort of a general increased risk in cancer with these mutations that don't have any, without one specific cancer type showing up. So what do we do for men? We're working on developing a more evidence-based approach to managing men with BRCA1 or 2 mutations. But at the current time, our guidelines state that we do breast screening at around age 35, which really consists of teaching breast self-exams, teaching men how to examine their own breasts, and having a clinical breast exam, which means a doctor examining your breasts every 6 to 12 months. We do sometimes use mammograms. This used to be part of the recommendations to consider. It's now still there, but a little less solid. And generally, we do mammograms for men who have breast tissue. Some men do have breast tissue, and others really don't. And it's always amusing to send a man with his wife to get a mammogram and then let them debate how pleasant it is. We also do prostate cancer screening starting at 40 with a PSA and a prostate cancer, and this is specifically recommended for BRCA2 carriers and considered for BRCA1 carriers. And this is a little different than for the general population, and so we'll talk about that in a little bit. As I think many of you know, there aren't specific recommendations now for PSA screening. It's very controversial, but we still do strongly recommend it for BRCA2 carriers in particular. Finally, in those who have a family history of melanoma or pancreatic cancer, we often will talk to individuals about ongoing trials for pancreatic cancer screening. There aren't specific guidelines for melanoma, but honestly, it's a skin exam, so we often do ask people to go to the dermatologist yearly just to sort of get a good exam and make sure that we're not missing that. In terms of lifestyle choices, in general, healthy lifestyle does seem to be associated with a reduction in cancer risk across the general population, and it also helps with other health conditions such as heart disease. So in general, our philosophy is, of course, not to smoke, maintain a healthy weight, be active, and to have at most moderate alcohol intake. And in BRCA1 and 2 mutation carriers, these effects may be relatively modest. Having said that, these are easy things to do for an overall healthy lifestyle, so we continue to promote them. Now, male breast cancer is getting more attention, which I think is really important. It can be stigmatizing for men to be diagnosed with breast cancer, feeling that it is, a woman's disease. The mammography clinics are all in pink. The breast cancer clinics are largely in pink. My breast clinic actually just changed the curtains in the exam rooms to blue, and I actually think that's an important first step. We just need to really back off on that and make sure that men know that they're at risk and get attention when they may feel a breast mass. So these are there's a movie that's just been out. There's been some New York Times pieces. So I think that there's a lot of different places to read more about that. But in general, when men are diagnosed with breast cancer, they often, they or their physicians tend to feel a mass. They have less breast tissue, so it's sort of between the skin and the chest wall. And you can note breast tenderness, swelling, lumps, nipple discharge. And so oftentimes this isn't associated with anything particular, but men tend to have a delay in their diagnosis of breast cancer with sort of a general sense that they're not really at risk. So we really do emphasize that it's important to get checked out if you're having symptoms. Male breast cancer in BRCA carriers and in the general population is usually a later onset disease, almost always after age 50 and usually after age 65. However, again, it's usually diagnosed at a higher stage, larger tumors, more often lymph node involvement compared with age-matched women. And again, this is in part because we can find cancers early by mammography, but also in part because men tend to have noticed the lumps for quite a bit of time before they get checked out. Doing mammograms, they take two radiographic plates and basically smush the breast, compress it between these two plates. It's done in the same way as men as it's done in women. but often you can get a pretty good picture in men because the breast tissue is not dense. And the treatment is the same for men and for women, and it's dependent on the stage and the type of cancer. So it usually for men involves a mastectomy, removal of the breast tissue, chemotherapy if needed, radiation if needed, and hormonal therapy. So for prostate cancer, this is, getting into this issue, is in the general population that the U.S. Preventive Task Force has recommended against prostate cancer screening for healthy men. And as the PSA screening rates have gone down, prostate cancer incidence has gone down too. And part of this is that with prostate cancer in the past, we were kind of good at finding cancer, but we tended to find both the worrisome kinds of cancer and the kind that wasn't as worrisome and was cancer that people could live with and not die of. And by finding both of those, you can overtreat some people, but an argument would be that if you don't look, you can undertreat others. And Dr. Bekelman, I don't know if you have any opinions or quick thoughts on this particular issue, which is always complicated.
Yeah, well, I think you hit the right theme. The main issue here facing men in prostate cancer screening is around what to do with the information and whether the information from the screening test is important. And my general recommendation is that patients engage with their doctors in what we call sort of participatory decision-making. In other words, talk to your doc. Ask if screening is right for you, why it may not be, and what the implications of a high PSA would be in terms of your treatment options. So I don't think that men should be scared of screening. I don't think doctors should be scared of screening. I think what all of this very important work done by the U.S. Preventative Task Force have done is help doctors and their patients, the men that I work with, understand that the screening test is less important often than just having the discussion about why to do it in the first place and what it could mean for them.
Well, thank you very much for that. I mean, there can be symptoms of prostate cancer too, although in the past we generally have found this by PSA screening. Urinary symptoms, particularly at night, blood in your urine, can all be signs of this, but they can also be signs of benign prostate conditions, and so that's why, again, talking to your doctor is important. There can also be pain, particularly in bony areas, swelling and things like that. So there's a whole array of symptoms that can be associated, and I'm a big believer that everyone should have a doctor that they can talk with about their medical conditions and their symptoms. So in the general population, most prostate cancers are diagnosed later in life and are slow growing, and if you will, to potentially overstate it a bit, but there is kind of a sense that if you looked in the prostate of all 90-year-old men, that many of them would probably have some low-grade prostate cancer that didn't ever harm them. And so the real question is, we want to identify and treat the worrisome prostate cancers that are going to lead to real harm, because prostate cancer can lead to real harm, and it's important to realize that as well. And so there are risk factors, including age, race, family history, whether or not you have a specific mutation, but those are all things you can't change. And then things like smoking and a high-fat diet, of course, can be controlled, although they're relatively modest effects. Sorry about that. So BRCA2 mutations are associated with an increased risk of prostate cancer, and it may have an earlier onset. BRCA1 mutations have not been, it's not exactly clear what the risk for prostate cancer is, but and whether it's elevated, but it does appear that the cancers may occur a little earlier. And as alluded to, the U.S. Preventive Services Task Force recently changed the PSA screening for the general population, but prostate cancer screening is still recommended for BRCA2 carriers. It's worth noting that even when you have an elevated PSA, a lot of the time it's still not associated with prostate cancer. and prostate exams can allow a physician to feel for abnormalities. There's been a number of specific studies that are looking at BRCA1 and 2 mutation carriers. One is called the IMPACT study. It's led out of the UK. And they and others have shown that BRCA2 mutation-associated prostate cancers are of higher grade and have a worse prognosis. And although BRCA2 mutations are uncommon in what we call unselected prostate cancer, meaning if you just look at just prostate cancers in general that are early on, that are early stage, you really just don't see very much. But if you look at higher grade tumors or individuals that metastatic disease, you find a larger number. And we're still coming up with sort of the exact values associated with that. So I'm going to just end on a note to just say for the men that there are different resources available. At the Vassar Center, we have resources on our website. FORCE is an advocacy organization that has a lot of information and advocacy and support. And there's HIS, which is a breast cancer awareness group for men that can be extremely helpful as well. And again, information, additional BRCA-related information, including information on cancer risk evaluation, genetic referrals, a research registry, and newsletter are available through vassar.org. Also here is the email address and the phone number, and we also have a Facebook page, but don't ask me how to use it because I'm too old for all that. And so with that in mind, and again, feel free to type in questions. I don't think we have any yet, but feel free to type them in. We are going to transition. Oh, nope, there we go. Somebody did have one. So I'm going to test. I'm going to quickly answer this question and then segue into Dr. Bekelman's. That question is regarding a family member who had testing, a man who's 31 and had testing through a commercial direct-to-consumer testing registry in which he was found to have a BRCA1 mutation. Also, it was something called an ATM mutation, but for what it's worth, a BRCA1 mutation wins. And you're near Pittsburgh, and the University of Pittsburgh does, through McGee, does have an excellent genetic testing program, so I would start there. If there are any questions or you're not getting the information that you need, please just email us at Vassar and we'll help get you connected. The next issue was whether why not ultrasound instead of mammograms for men. And the answer there is that ultrasounds actually have a lot of more false positives than do mammograms, and they're also harder to kind of keep track of because they're almost a video is the way to think of them rather than pictures. But we do certainly use supplemental ultrasounds when we need to. And I'm going to. There's a few other questions that maybe and that we'll try to answer as we go. One question, Justin, maybe for you, is whether vasectomy impacts cancer risk. Do you want to take that one?
Absolutely. So the answer to that question is, there was a large study that came out a while ago that seemed to indicate that amongst 10,000 men who'd had vasectomies compared to those who did not, that the risk of prostate cancer was higher amongst those with a history of vasectomy. But a challenge is that, on the other hand, there are many, many studies that haven't shown a link, and there were some sort of scientific problems with the study that did show a link. So what's the headline? In my practice and most of my colleagues at Penn, there's no sense and no concern that a vasectomy increases the risk of prostate cancer. Moreover, if you look at recommendations from the National Cancer Institute, the American Urologic Society, and some other societies, there's really just no sense that there's a link.
That's great. Thank you. And I think that the other ones I'll probably hit as we go, but if you want to start with the treatment options. One question was whether BRCA status impacted prostate cancer recurrence risk, and I think that the data, we're still working on those data, but it does appear that, yes, if you take sort of all comers who may have lower risk cancers, that because it's associated with higher risk, higher grade cancers, it does. The other question, though, is whether, if you will, a high grade prostate cancer without a BRCA2 mutation has a different recurrence risk as a high grade prostate cancer with a BRCA2 mutation. And I don't think we know that at all. I don't know, Justin, if you know any data to specifically answer that.
Yeah, I think that's right. And so I think what we'd be able to say to our patients and those listening on the call today is that for younger men diagnosed with a high-grade prostate cancer, or one that's come out of the capsule of the prostate, you can think about the prostate like a lemon, and the substance of the prostate is the pulp, and the capsule is the lemon peel. And so for prostate cancers that have come out of the lemon peel but haven't gone into the lymph nodes, those types of cancers in young men and those with a Gleason 8, 9, or 10, those are cancers that we would really consider a very serious discussion with patients about BRCA testing. And then the data's out on whether it impacts recurrence risk, but what I think we do know is that there's an association between BRCA status and aggressiveness of the tumor, and that's why we're concerned about it.
Great. All right. So maybe onto your slides for now as we're, one more. How valuable is PCA3 and 4K testing in conjunction with PSA screening?
Yeah, so in these webinars, we generally shy away from direct answers regarding any specific patients' cases, but I can say that generally PCA3 and 4K testing and additional testing, the PSA screening, is used a lot in the community amongst physicians trying to sort of develop a better way to help men make decisions about screening and then what to do with those results. It always depends specifically on what the overall picture is, the overall characteristics of the man undergoing screening, and then what all of these tests definitely show. These are common tests that are used. Our recommendation here at Penn Medicine is to make sure you're talking with a doc who has access to both the latest guidelines on PSA screening as well as the latest tools to be able to advise you on whether to be screened, and then if you are screened, what to do about the results.
All right, great. So I think we're on to your slides, although I'll keep interrupting you. Sorry, Justin.
No worries. We are, for those listening, we are actually happy to, we have 20 minutes left or so. We are happy to answer questions related to what we're talking about, specifically BRCA and prostate cancer. I have some slides on general treatment options for prostate cancer with a specific focus on radiation oncology. I'm a practicing radiation oncologist here at Penn Medicine with a focus on men with prostate cancer. There is a question here that asks, can BRCA carriers take testosterone, or does that increase risk? Low T, or the idea of a low testosterone level affecting men's health after the 40s, 50s, and 60s and into later years is an important sort of national health issue for American men. We also have a great program here, and this is a theme to most of my discussion, is talk to your doctor and ask the question. In general, testosterone supplementation is safe, provided there's been a screening assessment for prostate cancer. In general, once men are diagnosed with prostate cancer, we have to be very careful about testosterone supplementation because testosterone can be like the food that the prostate cancers feed off of and can motivate a recurrence. And so we have some general guidelines here for testosterone supplementation after the diagnosis of prostate cancer, which, again, we would be happy to discuss any individual patient's specific medical issues in a more formal consultation. Related to BRCA carriers and testosterone, there's no indication that a BRCA carrier who has not been diagnosed with prostate cancer would not be okay to take testosterone, but this is really it's an emerging field that we have to learn more about. Dr. Domchek, there's another question. Should I take that question or go into? I mean, the questions are interesting to respond to, but do you have a preference, or can I take this next question?
Oh, absolutely. I think we should just keep taking the questions. Yeah.
Right. Next question.
Yeah, that's a great question.
How do we know if a doctor is up to speed on PSA screening and treatment guidelines? In other words, what look for should we know about how a doctor responds to our questions? That's just a terrific. That's a terrific question that I relate to. That my family members ask me about all the time. I have a brother. I have many uncles, a father. All of them are constantly, as we all know, are constantly asking questions about their health, especially men's health and prostate cancer issues. I think there are some signals. With any type of cancer in general, we support National Cancer Institute rated centers. So any center that is a National Comprehensive Cancer Center is a marker of both clinical and research capabilities that have been evaluated by the NCI as particularly high quality. Many regions have more than one of these centers, and so they are certainly appropriate for folks to consider. Many patients, though, may not have access to those types of centers, and so then the question again is, in the community, how do I know whether my doctor has access to the latest PSA screening and treatment guidelines? I think it's just asking the question. If one of the major problems, and this is an area that we study here at Penn Medicine, is sort of the information asymmetry, or in other words, when we consume medicine as patients, we know much less than the doctor knows. It's sort of like when we buy a car, we know much less than the car salesman knows. And so the key is to try to ask questions of the physician to understand where their treatment recommendations are coming from. You could ask the question of the physician, you've recommended this, is that supported by any national guidelines that you're aware of? In general, I think what you're hearing from both Dr. Domchek and I is how important it is just to be able to talk with your doctor about the issues you're concerned about and try to understand and take some signals from that interaction whether that doctor is suitable for you. As we're going through these questions, we're also happy to take follow-up questions if we don't totally direct our answers to what folks are asking for.
Yes, so I think this will maybe go through some of the slides and see what other questions we come up with.
Yeah.
That's good.
So there are, what I'm going to do is give you a general review of treatment options for prostate cancer and then specifically go to radiotherapy. There are 4 main treatment options for prostate cancer once you've been diagnosed with prostate cancer. There's active surveillance with delayed intervention, surgery, external beam radiation, and brachytherapy. Active surveillance with delayed intervention used to be called watchful waiting, but today's version is not watchful waiting. It's not forget about you. Today's version of active surveillance with delayed intervention is actually it's a treatment paradigm. It's a treatment method that physicians use for patients who've been diagnosed with cancers that are unlikely to affect a patient's life. For those cancers, we can watch those cancers over time in a very precise program, and there are certain triggers that would allow us to recommend to the patient that they do actually get treatment. Under those types of programs, we found that about half of our patients who are suitable for those programs might not need treatment for several years or longer. when we say delayed intervention, about half of the other patients decide after a period of time that either they want to have treatment or there are some triggers that were met that would indicate that the cancer needs to be treated. So that's active surveillance. There's surgery. There are two options, robotic surgery and open surgery. In general, our recommendation around surgery and radiotherapy for these two procedural specialties is just go to a doctor who's done many, many, many of these cases and can speak to both the pros and cons of either approach. It's the same lesson that we would describe for external beam radiation. There's two main types of external beam radiation. One is called intensity modulated or volumetric arc therapy. They're very similar. These are X-ray based treatments. The other is called proton therapy. The last is brachytherapy. This is when a source of radiation is inserted directly into the prostate gland. I'm going to focus on sort of a big picture challenge in radiation for prostate cancer, and then some of the attributes of proton therapy, which many folks in Philadelphia have been exposed to because Penn Medicine has the Roberts Proton Therapy Center for the delivery of proton therapy across a number of malignancies. So the challenge in radiation generally is to deliver as much radiation to the target, the tumor, and cause as little collateral damage as possible. So we need precision and accuracy. And we've had that from better radiation systems over time, better imaging systems, and also better ways to track the tumor and then the tissue that's like the rectum or the bladder that's surrounding the tumor. So today's radiation is very different, in 2016 is very different from what it had been 5, 10, 15, even 20 years ago, where we've gone from conventional external beam radiation, which was sort of 1980s style, to what's called conformal external beam radiation that started with 3D techniques and it is now in its latest form, two different types of IMRT and then proton therapy. So there has been a question about vaccines in clinical trials. I'm going to get to that after I talk a little bit about proton therapy, and then we can come back to vaccines in clinical trials. So what makes proton therapy special? The main thing that makes proton therapy special is that the beam of radiation can come in through the skin, usually enters through the hip area, and then it stops and releases its energy at a point called the Bragg peak, which is typically at the tumor. The benefit of that is that, and some of these are, so the benefit of that is that radiation therapy that is delivered by IMRT techniques goes in one side of the body and out the other. And so in this chart, if you compare X-ray radiation to proton radiation, this chart depicts the excess radiation dose for an average tumor target that's within the center of the body. And it shows that with proton beam therapy, there's less exit scatter radiation dose. Another way to look at this is by looking at a cross-section of the pelvis. And in this cross-section of the pelvis, this shows the level of the prostate. And these are heat maps of radiation. So anything that's cold is blue, and anything that's hot or therapeutic radiation is red. So what you can see here with IMRT is that in order to get the radiation around the prostate, we distribute scatter radiation around the pelvis. Whereas with proton therapy, there's no scatter radiation in the back or in the front of this depiction, though there is, of course, some scatter radiation as it comes in through the hips. That seems like I'm going to just slip forward because of timing here. That seems like a no-brainer, but unfortunately it's not a no-brainer. It is a no-brainer in some cases for kids, for tumors in the brain or spinal cord, for certain tumors in the middle of the chest. But in the case of prostate cancer, there are some uncertainties in how we deliver proton therapy, and I'm just going to go to the bottom line here, that leads us to overshoot the prostate, almost regardless of the technique we use. So if we look at the close-up here of these heat maps in the pelvis, where the circle in the red on the IMRT side here is covered by a very tightly conformal area of red, which is the therapeutic radiation. And then you look at the proton side, what you can see is the therapeutic radiation actually overshoots the prostate a little bit. That's on purpose. We do that because of the particular characteristics of proton beam therapy. And in some techniques, it appears a little sharper for protons. But there's nothing we can do about that overshooting. And so what that means is that some normal tissue that's not prostate is exposed with proton beam therapy to the therapeutic radiation, whereas with IMRT it's typically exposed to more colder radiation. So what's the bottom line in terms of this short educational series about prostate cancer and these two different types of radiation? For IMRT and proton therapy, the pros, they're both highly conformal, excellent treatments, almost like a Mercedes versus a BMW for prostate cancer. You almost can't go wrong regardless of which treatment technique you use. Some of the cons for IMRT, there are some hot spots. There's what we call the low-dose radiation bath. That's the scatter radiation that was demarcated by blue. With proton therapy, some of the cons are that there's overshooting. Some of that overshooting happens because the protons are more sensitive to the structures of the body in the pelvis than IMRT. What do we generally tell our patients when they come here thinking about proton therapy? It's a terrific treatment for prostate cancer. So is IMRT, so is surgery, so is active surveillance with delayed intervention. And what we also tell patients around proton therapy is that and IMRT, and frankly any of these procedural techniques, including surgeries, that it matters which center it matters you go to, the physicians and the staff and their experience, and then the quality and safety program at that center. So I'm going to conclude there. There is one question that we have: what about vaccines in clinical trials? So I can answer that specifically for prostate cancer. In general, there's really great potential for immunotherapy and vaccines in prostate cancer today. Typically, it's being evaluated and tested amongst patients that have metastatic prostate cancer, in other words, cancer that's spread outside of the prostate and pelvis and either into the lymph nodes or bones. These vaccines are not yet used in the what we call the curative setting, or the setting where the cancer is still confined in the pelvis below the belly button.
And I can add one piece to that, which is that we and others are working on vaccines with the ultimate goal, we are not doing this right now, but with the ultimate goal of administering vaccines to prevent the development of cancer altogether. So there is a vaccine that is actively enrolling at Penn for individuals who have had a cancer that is, that has been quote-unquote treated for cure, but these people are at risk for their cancer coming back. Right now, prostate cancer patients are not included in this study, so it's breast cancer, pancreatic cancer, lung cancer patients, and they get a vaccine to see whether or not that can help prevent the cancer from coming back. In the process, we're learning about the safety of that vaccine and whether it's generating the appropriate immune response, with the goal of eventually having that vaccine given to BRCA1 and 2 mutation carriers to prevent them from developing tumors in the first place. So, it is an active area. People, often kind of say, why aren't you doing more to try to prevent cancers? And we are trying. So that's the only other additional comment I have.
Great. Well, it looks like we don't have any other questions. Thank you to Dr. Domchek and Dr. Bekelman. Today's presentation will be archived and available for viewing this week, along with past Vassar Center webinars at vassar.org/webinar. Our next webinar will be on June 9th at 12 p.m. Eastern, where Dr. Domchek will be discussing the ABCs of cancer risk. That means things like defining the key terms related to cancer risk, understanding why risks are represented as ranges, research about looking at cancer risk by mutation type and location. You can register for that webinar also at vassar.org/webinar. Thank you again to Dr. Edward and Merry Prostic for making this event possible. Enjoy the rest of your day.